gentlemen. May I congratulate Dr. Ahmed Taha for the perseverance of making such a wonderful event coming back to life, and congratulate all of us to be all together here. Mr. Chairperson, I'm honored to chair this session with you. I would like to present the first presenter, Professor Dr. Thomas Zgonis from USA, presenting surgical management of severe foot infection and osteomyelitis. Professor Thomas isn't here. Okay, while it's a live transmission, I hope we start.
Professor Thomas isn't online yet.
So we transfer to the next speaker, presenting the principles of diabetic food debridement, Professor Venu Kavarathpu from UK.
Thank you very much, respected Chairman. Ladies and gentlemen, I feel honored to stand in front of you to discuss about the principles of diabetic foot ulcer debridement. I bring greetings from the King's College Hospital Diabetic Foot Unit. I'm the orthopedic reconstruction lead of our unit. I joined 16 years ago with Professor Mike Edmonds. And when I joined, it was a very small team. This was about 9 years ago. And it has grown to a large multidisciplinary team, perhaps one of the largest in the world. And that coincided with our 40th anniversary when the unit has been renamed as Mike Edmonds Foot Unit. And I'm very proud to be part of this wonderful team. Before I take you through my views on the principles of diabetic foot debridement, I would like to emphasize on the need for appropriate diagnosis of infection. We had fantastic lectures earlier on the usage of MRI and vascular side. And in addition to that, I would like to emphasize on the role of bone biopsy and deep tissue specimens. This is the most important key intervention or investigation in our unit that helps us to keep pushing the boundaries. Bone biopsies provide amazing insight into the diagnosis and also the activity level of the infection. And equally, deep tissue surgical specimens during your debridement, if done appropriately using certain protocol, are also extremely valuable. So this is our gold standard investigation method for all. So once you determine the diagnosis of infection, the assessment of the severity of the infection, you then decide the surgical treatment. There's no doubt antibiotics have very little role on the management of necrotic infected diabetic foot ulcer, and we are all too familiar with that. And as this paper from the Association of Diabetic Foot Surgeons pointed out, so the key intervention is the debridement that influences the immediate and the long-term outcomes. The aim is to achieve infection eradication, and it's very clear that the quality of that debridement has to be really, really good. Let me share this information from our internal audit that was performed in 2009, 3 years after I became a consultant. What we found out was that the redebridement rate of diabetic foot infections was 1.2 when it was done by, I was the only foot and ankle surgeon at that time. Those done by me, and I felt unhappy that some of them had to go back. But if you look at the other orthopedic colleagues who don't do or who don't have the concept of the quality of debridement, it was much higher. So that initiated a single referral pathway for all such presentations in 2013. So all diabetic foot infections are referred to us. Means at that time it was me, but the team has grown. And that redebridement rate still remained low. And that resulted in doing the scientific study and this paper, which is considered as one of the key papers on the quality of surgical debridement by my colleague Raju Aluwalia. What we see here is a diabetic foot ulcer. It has the red zone, the zone of injury, which is obviously infected necrotic, and that is surrounded by the zone of reactive zone that has scar tissue, granulation tissue, and that has pockets of infection here and there, that is surrounded by healthy zone. We're all familiar with this. But this study has re-emphasized that. So this ulcer was debrided, as usual, by the orthopedic trainee. And when we extended the incision, clearly it shows a very wide necrotic zone, the amber zone. All of that has to be excised. Down to the green zone, then only you will see very predictable wound healing. Another example of very inadequate debridement for a diabetic foot attack from the referring team. Clearly, all of that was necrotic, including the Achilles tendon. If that is infected, there's no chance that it will recover. A healthy tendon got infected, unhealthy tendon will never recover. All of that has to be excised. On this occasion, with vac dressing and continued bedside debridement, and then good granulation, skin grafting, and then we thought about the deformity correction. But there are some subset of diabetic foot infections that require a special attention. If that infection is presented, if it presents with spreading redness, spreading swelling, tissue necrosis, or purulent discharge that is spreading, that is quite a different kettle of fish. This rapidly spreading erythema, the local warmth, and the patient becoming systemically unwell. We're not talking about routine ulcerative infections. So the presence of these three clinical features warrant a different kind of recognition of such infections called diabetic foot attack. It is really critical that we as clinicians recognize such infection presentations. And again, our team has written a very well recognized article on this. And here the time is tissue. And if you delay it for too long, yes, if there is time, you can do an MRI. And you should do an MRI, but surgery should not get delayed. If there is time, you can do full vascular studies. But quite often, there's no time. So it is critical that we recognize this equivalent of an MI, cardiac MI, or a CVA of the foot. So what happens here is that there's often some minor injury, skin break, blister, that ulcerates, but on this occasion, cellulitis spreads. And there is, in delayed presentations, tissue response, and you can physically see the tissue necrosis, and that rapid progression is the diabetic foot attack. So here, we need to diagnose infection rapidly, culture the bacteria responsible before you start the empirical antibiotic therapy based on your local protocols, early surgical debridement. There is absolutely no role for non-surgical management for such presentations. It's not only the limb at risk, the life is also at risk. This one, again, very poorly debrided at the local hospital. It required quite aggressive debridement. You can see the pus pouring out along the tendon sheaths. The tendon sheaths are the highways, or super highways of these infections. Then extend until you see the full extent. So on this occasion, this required 2 repeat debridements. But once you see no further infection collection, no further spread, once you see good granulation, you can go for skin grafting and the deformity corrections if required. So here, there is a role for deformity correction. Some ulcers present with no significant deformities, some present with significant deformity. This is a minor exostosis, you can say, but this ulcer hasn't healed despite repeated debridements and offloading. Unless if you remove that bone prominence, the ulcer will never heal. It keeps getting infected. So it requires the same principles I described earlier, very aggressive debridement. But if you look at the calcaneal pitch here, that is abnormal, that is negative. Normally, the calcaneus should be the other way around, pointing. So that has to be properly addressed. So here, the Achilles tendon is very tight. That is released. We do percutaneous TA release procedures. Ideally, a midfoot reconstruction would be appropriate here, but on this occasion, at this presentation, simple exostectomy. You can see the calcaneal pitch has improved, and again, with VAC therapy, it results in predictable healing. How about major deformities? This midfoot Charcot with large bone prominence and rocker bottom foot, just simple ulcer debridement will not result in permanent ulcer healing. The ulcer simply comes back. If there is a minor deformity, yes, offloading helps. But such major deformities, on this occasion, the midfoot with infected ulcer, again, this is the modern surgical treatment. they have to be managed surgically using these principles, all orthopedic, but still a hind foot, again, that has to be reconstructed. Now the results are fantastic, much better than compared to 10 years ago. Combined hind foot and midfoot, they need to be reconstructed as well after addressing the ulcer problem. So to summarize, when you come across an infected diabetic foot ulcer, I would like to re-emphasize, you're all absolutely familiar with this, you follow these principles, but I would like to re-emphasize our humble experience that when we apply these principles of identifying the red zone, amber, and green zone, our debridement goes up to the green zone. And then you can think about whether you want to do local tissue flap or address the associated deformities subsequently. But we have seen very, very predictable wound healing with this particular principle. Thank you very much.
Thank you, Professor, for such a very interesting presentation. Now we have Professor Thomas with us on live, so we can bring him, please, to the stage. He's presenting a very important topic of surgical management of severe infected and infection with osteomyelitis. Professor, I wonder if you can hear us clearly.
Can you hear me? Can you hear me good?
Yes, sir.
Yes?
Yes, sir.
All right. Good morning. Good morning from San Antonio, Texas. First of all, I would like to thank Professor Ahmed Taha, the organizing committee, and DF Care for inviting me today to share with you my experience with treatment of the diabetic foot. So, most common causes for diabetic foot amputations, as you see here, include ischemia, gangrene, underlying infection, osteomyelitis, peripheral vascular disease, peripheral neuropathy, patients with uncontrolled blood sugars, multiple comorbidities, chronic open wounds, as you heard, previous lecture of chronic Charcot foot neuroarthropathy, and socioeconomic status. The surgical goals of the management for severe diabetic foot infections and osteomyelitis, as you see here, most importantly is to eradicate the presence of infections, systemic or localized, maintain a durable soft tissue envelope after surgical debridement, as you saw in the previous lecture, correct any underlying structural deformity. The goal should be to establish a plantigrade embraceable foot and ankle, prevent the incidence of re-ulceration or re-amputation, and lastly, most importantly, is to restore lower extremity function in a diabetic population. Surgical management of diabetic foot infection and osteomyelitis is a multidisciplinary team approach, which is, to my experience, can be performed in large academic centers or healthcare systems where all the medical and surgical teams are readily available. Surgical debridement, anesthesia considerations for the diabetic patient, since they might be undergoing multiple debridements, vascular assessment by the vascular surgeon, basic arterial non-invasive studies, and endovascular surgery versus open bypass surgery, treatment of infection with infectious disease specialists, surgical and medical treatment, medical management of comorbidities with a cardiologist, nephrologist, internist, as you see here, interventional cardiology in most of the cases, endocrinology, since these patients come with multiple comorbidities, delayed reconstruction, soft tissue, osseous reconstruction, and external fixation. And lastly, very importantly, postoperative management with rehabilitation, wound care, adjunctive hyperbaric oxygen therapy, as well as family and social support for the diabetic patient. Here I'm going to take us to some cases with severe diabetic foot infections and osteomyelitis. This is a patient with gas gangrene, urgent emergency situation with a diabetic limb-threatening infection. Here is the patient after the first stage with extensive debridement. However, patient had multiple osteomyelitis to the joints of the third and fourth metatarsophalangeal joint, septic arthritis, gas gangrene. Patient ended after the first surgical debridement with transmetatarsal amputation and extensive debridement dorsally for the gas gangrene. Patient had an intraoperative negative pressure wound therapy, as you see here. Patient was discharged with the hospital with PICC-line antibiotics, further wound care for postoperative management. We waited approximately 9 weeks after the negative pressure wound therapy, as you see here, to bring the patient back for another surgery of autogenous split-thickness skin graft from the ipsilateral leg to the foot, as you see here. We applied the negative pressure wound therapy on the superior surface of the split-thickness skin graft. We kept the negative pressure wound therapy for continuous 5 days in a low pressure setting. And here's the patient after posterior splinting, non-wavering status, and long-term outcome of diabetic limb salvage with severe diabetic foot infection. Here's another patient with severe calcaneal osteomyelitis, abscess purulence, was stalled by minor services for below-knee amputation. First, initial surgical debridement, extensive debridement to eradicate any infection underlying soft tissue or osseous with partial calcanectomy and extensive debridement. Patient waited approximately 3 to 5 days to be brought back for multiple surgical debridements every 3 to 5 days while the patient was hospitalized. Patient had a negative pressure wound therapy, as well as external fixation. This is where the external fixation, a very simple surgical offloading technique, as you see here, for daily or any wound vac changes, for visualization of your wound, for stabilization of the foot to the leg, and it makes it easier for patient compliance to apply a very simple surgical offloading technique with external fixation for your wound vac changes. Here the patient was brought back for split-thickness autogenous skin graft due to peripheral vascular disease. No other flap was available. And here's the long-term outcome of the patient with diabetic limb salvage techniques. One of the most common applications of eradicating local infection is the application of non-biodegradable antibiotic cemented beads or spacers. The advantages of using those non-biodegradable antibiotic beads or spacers, they can fill in large osseous and soft tissue defects. They have higher elution rates, the beads, and structural support of the spacers. The most common one commercialized is the gentamicin and tobramycin. You can also add vancomycin based on your intraoperative cultures, and has better compliance and also decreases the risk of prolonged systemic antibiotic therapy. So the gentamicin, as you see here, it can last up to 3 months, up to 90 days. They're released from the antibiotic beads or spacers. And you can see the vancomycin levels decrease with the second week on the 12th day. Some other common antibiotics is cefazolin, ciprofloxacin, very rarely used for antibiotic cemented beads or spacers. The disadvantages of having non-biodegradable cemented antibiotic beads, you need additional surgery for removal. Sometimes in the literature you have seen potential antibiotic resistant and systemic effects, and also potential effects in bone and soft tissue healing. There is a lecture later for options of biodegradable products such as calcium sulfate mixed with vancomycin, again, or bone allografts with antibiotics mixture. Again, more literature, more evidence needs to be on those products, even if it's biodegradable, non-biodegradable. But again, the biodegradable ones, they have very minimal structural support. So here's some more cases to show you the application of cemented, non-biodegradable antibiotic beads or spacers. Here's a patient with calcaneal osteomyelitis posterior aspect, severe peripheral vascular disease, was offered below-knee amputation multiple times. We brought the patient back for very minimal partial calcanectomy. due to peripheral vascular disease. Here you can see the insertion of the Achilles tendon is still intact. Application of non-biodegradable cemented body beads 5 days after the original surgery. As you see here, patient closure. Here's the posterior splint, and also you can see the patient had a lower extremity bypass surgery before our revisional partial calcanectomy with antibody beads. Here's the long-term outcome of the patient. We waited 3 months to remove the antibody beads, take further cultures, and final limb salvage after a lower extremity bypass intervention, minimal partial calcanectomy, and application and removal of antibiotic beads. Here's another case with diabetic foot osteomyelitis, gangrene, surgical emergency with a soft tissue gas and osteomyelitis in the lesser metatarsophalangeal joints. I discussed with the patient that they will have multiple surgical interventions, but infection control, the first surgery will be an open transmetatarsal amputation or disarticulation of the toes, followed by vascular intervention, studies, and revisional transmetatarsal amputation. Patient was brought back for revisional transmetatarsal amputation, application of antibody beads to fill in a large soft tissue defect and osseous defect. And here's a closure of the transmetatarsal amputation with the application of antibiotic beads based on your intraoperative first cultures. And here's the long-term, as you see, outcome. Remove the beads within 10 weeks and 28 months follow-up of a transmetatarsal amputation with removal of antibiotic beads. On the diabetic Charcot foot, with severe osteomyelitis and infections, with a very large osseous defect. As you see here is a patient with acute osteomyelitis, Charcot neuroarthropathy. As you see the clinical radiographic findings with osteomyelitis in multiple midfoot, rear foot joints. The patient was brought back for initial debridement, medial lateral incisions, and then was followed by medial cuneiform resection. Here's the initial surgery. Then we brought the patient back to remove any underlying osseous infected bones and soft tissue. We've applied antibiotic spacers medially and laterally, as you see here. The spacer on the medial joints, the antibiotic beads on the lateral joints. We waited approximately 3 months to remove the antibiotic beads and spacers. Brought the patient back to do the definitive arthrodesis on the medial lateral columns with allogenic bone graft. As you see here, after we remove the beads and the spacers, external fixation for stabilization, compression, and arthrodesis. As you see here, here's the clinical radiographic findings. And lastly, remove the external fixation approximately 7 weeks, followed by cast immobilization. And here's the long-term outcomes of the patient with severe diabetic foot infection and osteomyelitis. And here's the long-term outcomes.
Dear Professor Thomas, we are actually running out of time. We have exceeded the allocated time, so please wrap it up, please.
Great. And the last case here, as you can see, with antibiotic spacers, the same case with the same technique. For conclusion, I think more research is needed to be used for non-biodegradable antibody beads, close patient observation with infectious disease management, and multidisciplinary medical and surgical teams are in need for the patient's best outcome. Thank you.
Thank you, Professor. Well, thank you, Professor, for a very elegant presentation. May I call to the next presentation, the management of diabetic foot osteomyelitis by Professor Jose Lazaro from Spain.
Okay, next Mac. So good morning, everybody. Thank you very much for the kind invitation to this conference, especially for Professor Ahmed Tahak. I'm going to present this lecture about the management of diabetic foot osteomyelitis. That is quite, I don't know why I can't see my presentation on my screen, please, because I see the Professor Thomas. Okay, thank you. Thank you so much. So I'm going to deliver this lecture about the management of diabetic foot osteomyelitis in a very, very limited time, and I try to be very clear about the concepts. So I don't have any conflict of interest about this presentation. First thought, I would like to introduce a very specific points about diabetic foot osteomyelitis. Why is important osteo and diabetic foot? The first reason is because it's the most frequent infection among diabetic foot. The second is because it's associated with poor patient outcome and high risk of amputation. The third reason is because it's considered one of the main barriers. Sometimes the ulcer is not healing because you have the osteomyelitis and sometimes you don't know. And the last one is the difficulties and controversies in the diagnosis and treatments. My presentation is not focusing especially in the diagnosis, but I think it's very important to spend only 30 seconds to remind you about the diagnosis of diabetic foot osteomyelitis, and especially look at this picture. This patient suffers from osteomyelitis. Probably it's not a medical urgency. Probably many of you is sending back the patient to home, but this is the beginning of the syndrome, diabetic foot syndrome, in the majority of the countries among the world. Remember that according to Eurodial study, the majority of the ulcer in Europe is less than 5 centimeters square. So that means that a small ulcer in the lesser tooth. And this is sometimes the beginning of the complication of diabetic foot. So, just for a reminder, this is an info card for the DFoot International that we developed when I was a president of DFoot International, and remind the 3 steps for diagnosing diabetic foot osteomyelitis. It is very simple. If you can combine protein test, X-ray, and inflammatory markers, especially erythrocyte sedimentation rate. So remind, because it's very important. Forget MRA. MRA is for most advanced state, but if you can start to diagnosis, you have to perform in every patient that you have with an ulceration these 3 steps: blood to bone, X-ray, and inflammatory markers. We are going to management, to the treat. What should I treat this diabetic foot osteomyelitis? How many of you vote for surgery? You can hold your hands. How many of you? Nobody? Here there are a lot of surgeons. Only 3? How many of you are going to antibiotics? The rest of you don't think to treat the patient? Okay, we are going to try to discuss about this, because there were a scientific battle between surgery or medical treatment of diabetic foot osteomyelitis. And especially, I traveled a lot among the world delivering lectures about what is the best treatment for diabetic foot osteomyelitis. And do you know what? There is not the best treatment. There is the best indication. And the indication is up to you. So it's very important to select the right treatment to get the better outcome. And for this reason, we need to start. The first consensus, what is the first consensus about management of diabetic foot osteomyelitis? Osteomyelitis is not a single disease. All the picture that you are seeing here, all these patients has osteomyelitis, but probably not all needs the same therapy, the same treatment. So this is the first consensus agreement. So what is the indication for surgical management? So the surgery is mandatory in this condition, when the infection is associated with substantial bone necrosis, when there is a persistent sepsis, when the patient cannot be treated on a patient basis, when there are complications associated with the use of antibiotics, when the pathogen is resistant to available antibiotics, when the vascular involvement of the foot, especially in the mild and moderate ischemia, when the patient has a preference for surgical treatment, and when the patient is hospitalized. In this condition, the best option is surgery. So this is the indication, the different indication. There is another consensus internationally. This is a strong agreement, the indication for surgery, and this commenting on previously mentioned by other speakers about diabetic foot attack. especially when the diabetic foot osteomyelitis is associated with substantial bone necrosis, with necrotizing soft tissue infection, when immediately risk for limb loss, or which is associated with the presence of abscess. In this occasion, when surgical debridement is required as a part of control of the spreading infection. So this is clear, and I think the majority of you agree with me with this indication. The question is, what kind of surgery? Or in other words, surgery means always amputation? If you have a patient with osteomyelitis in the second toe of the foot, you are performing an amputation in all of the case? Be honest. I think the majority of you, yes. And it's happening in the majority of the countries among the world, not only here in this area, in Europe, it's happening. But we need to transfer or to change our mentality about the classical surgery, only amputation. When you diagnose osteomyelitis, the only way is amputation with conservative surgery. Conservative surgery is another kind of approach. And I'm going to deliver, and I'm going to talk in another conference about this kind of surgery. So, in summary, you need to be training in surgical approaching of diabetic foot. Some of you are vascular surgeon, some of you are orthopedic surgeon, some of you are plastic surgeon, but how many are foot surgeons? You need to be training in this specific foot surgery. This is very important. Another important question, what happens with antibiotics after surgery? So when you are removing the bone infection, the whole bone infection, do you think that the patient needs 4 antibiotics? The majority of the protocols recommending to maintain the antibiotic, but it's very important to have in mind that the use of antibiotic has to be the less time that you can. So the shorter treatment of antibiotics you can use, the better for the patient in order to avoid bacterial resistance. This is very important. So if you are performing surgery, perhaps you only need a short period of antibiotic after surgery, especially 1 week, 5, 7 days. The other alternative, antibiotics. I don't know how many medical medical doctors are here, not only surgeons, but this is another option because sometimes the patient can be treated only with antibiotic, and especially in this condition. Very well perfused patient, so that means neuropathic ulcer without peripheral vascular arterial disease, without necrotizing soft tissue infection, without exposed bones, confining in the forefoot, in patient who is very easier to offload, and there is not other mechanical causes for surgical treatment, and there is an appropriate antibiotic regime. This is the main indication for antibiotic. The problem is in the majority of the case, we didn't find, or we are not going to find this kind of patient because the majority of these patients when came to the hospital came in worse condition than here. So sometimes is the starting of the problem. Other question, can I treat of this patient with antibiotics in the same regimen? Remember, the majority of our patients has renal failure, has peripheral arterial disease, some of them with the bone exposures, some of them with previous antibiotics that can produce bacterial resistance. So it's easier to select the correct antibiotic for this regimen of treatment? Probably not. And another condition, the duration, how many times, the depth of the ulceration. It's important the previous antibiotic that the patient is taking, the bone bioavailability. So in summary, it's not easier. This is a recommendation for the international protocol, but sometimes it's not sweet for all the patients. So the recommendation is to take the bone culture. But if you have to take the bone culture, you have to perform a surgery. And if you only are a medical doctor, sometimes it's not possible to perform a bone culture. So this is another barrier for antibiotic treatment. Another important point, the parenteral administration has any advantage in the treatment of diabetic foot osteomyelitis comparing with oral antibiotics? The majority of the medical doctors think, yes, parenteral is better. No, it's not better, and especially in this chronic infection where the duration of the treatment is so long. So it's the same if you select the right antibiotic. So very important to select the duration of the therapy for weeks. Yes, the time is up. Sorry, I'm going to I don't know if I can to finish my presentation. Okay, thank you. Just to remind that you need only to follow the patient for 4 weeks, and if the patient don't have any outcome, you need to reconsider the option for surgical treatment in this gallbladder infection. Just for finishing my presentation, and sorry for my delay, 2 important recommendations about the follow-up if you are treating only with antibiotic. Check the erythrocyte sedimentation rate and check the change in the S rate when you are treating patients with antibiotic. Thank you very much for your attention.
Thank you indeed, Professor, for such an instructive lecture. Now we're going back again to Zoom with Professor Thomas from USA presenting diabetic Charcot reconstruction. Is Professor Thomas?
Yes.
Yes, thank you, sir.
Hey, can you hear me?
Yes, sir. Very well heard.
Already? Okay. The next lecture is diabetic Charcot reconstruction, and most common surgical indication for the
Professor,
diabetic.
Please share your screen.
Yes. It's, let me
No,
see here.
you didn't share your presentation yet, Professor.
Yes.
Okay, perfect.
Yes, that's
Thank
it,
you.
sir.
Most common surgical indications for the diabetic Charcot foot reconstruction include gross instability and deformity, any unsuccessful conservative treatments with casting and immobilization, severe fractures or dislocations, patients that are ambulatory, and they have previous chronic ulcerations or bone infections. What we consider before any type of Charcot reconstruction, the acute or chronic stage, is if the patient has had any previous surgical interventions, if you have retained hardware, history of open wounds, osteomyelitis, the anatomical location, if it is the midfoot or the hindfoot ankle, so with different types of fixations, if the deformity is stable or unstable, does the patient have equinus contracture, is the patient ambulatory, the patient's age, the comorbidities, underlying vascular disease, family, social support, and adjunctive therapies. So here I'm going to take you through different anatomical locations of the Charcot foot with or without the presence of any open wounds or osteomyelitis. So we start with the midfoot at the tarsometatarsal joint, the most common joint with a diabetic Charcot foot deformity. So these are patients without any history of wounds or osteomyelitis, with a severe fracture dislocation, very unstable deformity, that you can use internal fixation, external fixation, or a combination of both, depending on the anatomical fracture and dislocation. Here's a patient with application of internal, external fixation for realignment, arthrodesis, further stabilization, and long-term outcome with a medial column arthrodesis on a patient with diabetic Charcot foot and peripheral vascular disease, and again on the midfoot without any evidence of wounds or osteomyelitis. Here's another patient with a fracture dislocation on a diabetic patient on a midfoot without any wounds or osteomyelitis. Same technique, internal with external fixation, medial column arthrodesis, and you can see the retained internal fixation in these patients without any history of wounds or osteomyelitis provide prolonged stabilization for the deformity correction. A patient, however, again, now we're staying on the hindfoot ankle. We'll move an anatomical location more proximal on the ankle joint. And you can do one stage here if they don't have any wounds or osteomyelitis. This is a patient with a severe instability. You see the talonavicular joint on the hindfoot ankle. However, the patient had no evidence of any wounds or osteomyelitis. So here you can see the clinical radiographic findings. So one stage surgery in these patients without any wounds or osteomyelitis. Here's an acute talectomy at the ankle joint. You can see here with autogenous iliac crest grafting for a tibiocalcaneal navicular arthrodesis, external fixation, and you can see here one-stage realignment. As you see here, external bone stimulation as well, and anatomical alignment on the patient with that severe fracture dislocation on the hindfoot ankle. One-stage surgery. However, the surgical principles are thought differently if the patient has a history of open wounds or osteomyelitis. Now we are to the midfoot level, where with a Charcot deformity and osteomyelitis, it requires stage reconstruction. So usually they get the initial debridement. We're waiting for the bone and soft tissue cultures and bone biopsy before we will bring the patient back for any type of reconstruction. In our surgical hands and techniques, in our literature, external fixation is ideal on patients with any prior history of open wounds or osteomyelitis. So here's a patient in the midfoot with osteomyelitis, open wound, non-healing, where the patient had initial surgical debridement, brought back for an abductor hallucis muscle flap closure, arthrodesis, external fixation, and long-term outcomes or harvesting the abductor hallucis muscle to cover the medial wound with osteomyelitis on a Charcot patient. However, on the hindfoot ankle with a history of, as you see here, osteomyelitis, fracture, dislocation, open wounds, the patient will have an initial surgery, as we said before, with excisional debridement. As you see here, medial lateral incisions, acute talectomy of the infected bone, and we'll bring the patient back for further external fixation devices, negative pressure wound therapy on the wounds, and then split-thick skin graft on the wounds while the external fixation was on. Here is the compression, and here's the long-term salvage outcomes on these patients with wounds or osteomyelitis on the hindfoot ankle. The next category is the revisional diabetic Charcot arthrodesis after failed open reduction internal fixation. These are more challenging cases since we have to make larger incisions, remove the internal fixation, and most of the times use a different type of device to correct the underlying deformity. Here is a patient with multiple internal fixation failed devices for Charcot neuroarthropathy that had multiple ulcerations, instability. Here we made a medial incision to remove the hardware, lateral incision to approach the tarsal joint from the medial implantar aspect of the foot. Here removal of all the broken hardware, very large osteotomies, and correctional arthrodesis revisional surgery. So here you can see allogenic bone graft. Here is the medial implantar incisions. Here is more of a computerized external fixation devices and realignment. Here you can see the external fixation devices and realignment. And here's the long-term outcome with compression arthrodesis across the tarsal metatarsal joint with two different incisional approaches. And here's another patient on the hindfoot ankle with failed internal fixation, as you see here, with after open reduction internal fixation of an ankle fracture with Charcot neuroarthropathy. So here the patients will have removal of the hardware and arthrodesis, as you see here, with allogenic bone graft on the ankle joint. Here's external fixation after failed open reduction internal fixation of hardware. For arthrodesis realignment, here's your realignment technique and arthrodesis with external fixation. And here's the long-term outcome after fibulectomy, talectomy, and external fixation without any hardware retained after the revisional surgery. And here's the long-term outcomes and skin graft on the surgical incision. So to minimize complications for the diabetic Charcot foot and ankle surgery, again, multidisciplinary team approach, large academic or healthcare systems, adequate blood flow, appropriate fixation. The surgeon has to be well-versed in internal, external, or combination of those two systems, and traumatic soft tissue handling, plastic surgery techniques, infection control of any underlying infection, protected non-weight bearing status after the external fixation removal, adjunctive therapy such as orthobiologics, external bone stimulation, And lastly, postoperative management and rehabilitations for these diabetic Charcot patients. Thank you.
Thank you very much, Professor. Now we're moving to our next presenter, Professor Dr. Martin Arizol from UK, presenting a very important topic, role of topical antibiotics in treatment of foot osteomyelitis.
Thank you very much for inviting me. Can you hear me, everybody?
Yes, very well heard. Welcome.
Okay, I'll just share my screen. Okay, thank you very much for inviting me to speak at this conference. It's an honor and a pleasure. Hello?
Can you close the presenter view?
Oh.
On the upper left of the screen, there's display settings. Can you choose this? Yeah.
Close that display settings.
Yes, press it, please.
Yeah. So to prevent a view or?
No, duplicate slideshow.
Is that it?
Thank you.
Brilliant. Thank you very much. Sorry for that. Yeah, so I just wanted to give you a live case study that from a vascular podiatrist perspective here at Guy's and St Thomas Hospital in London. Typical patient, type 2 diabetes with poor glycemic control, late 60s, female patient with peripheral vascular disease, previous history of femoral and crural disease, and had a history of fourth toe amputation in the past as well. So this lady presented to us in the clinic with a left foot, critically ischemic limb with lots of tissue loss. I think she had an infection emanating from this fourth toe amputation site, which was previously amputated, but obviously hadn't fully healed. So she's got lots of necrosis to the forefoot as well, and a spreading pyogenic infection across the whole forefoot. So this was a pretty late presentation because this was around the beginning of COVID. So the patient decided not to tell us about it until it actually presented like that, which is quite typical of a lot of our patients. So diagnostics, we don't need too much imaging to tell us that there's infection, but there's also a lot of osteomyelitis going on there. So apart from the fourth, which is being amputated, we have now got osteomyelitis around the third toe and then the fifth, getting away possibly of the second metatarsal there. So what do we do for this patient? So we gave her a scan and realized that her popliteal and crural vessels were all occluded, but she had got some collaterals which were feeding down to the foot. She had a deteriorating renal function, so we decided to give her a CO2 angioplasty, and then we're able to open up the anterior tibial and popliteal arteries to the foot. And then we decided to take theatre and then take away that third and then the fifth toe amputation. So you can see the tissue is now a little bit better perfused. The skin's a little bit more pink and it's presenting nicely. So the patient was doing very well after several months, discharged with topical negative pressure. But then we had readmitted her. Again, a little bit of a late presentation to come to clinic with foot sepsis, foot pain, rescanned her and found that she completely occluded every vessel in her leg on that side. All the crural arteries were completely occluded. So we started on thrombolysis for several days and then attempted to angioplasty, but noticed some trash distally. So the ATA, which was the only vessel running, was beginning to show some thrombosis distally and into the dorsalis pedis as well. So continued thrombolysis for a few more days, and then after that, we took her back to the IR, interventional radiologists were able to do a fantastic job of opening up with another CO2 of the SFA and ATA with some straight line flow to the foot. And as you can see, the interventional radiologists are excellent at getting good flow back to the foot. I can't show you the foot pictures on this image here, but I can assure you there was better flow to the foot, straight line flow to the foot, but obviously microvessel circulation was still going to be an issue. So now we have flow to the foot of this patient. What do we do about this clinical osteomyelitis? And we know there's diagnostically that we can see some bone infection of the distal parts of the metatarsals here. So we took her back to theatre, knowing that we had a better blood supply. The only way we're going to treat these patients is to improve the blood supply first, and then start debridement of bone if we have to. And in this case, we were able to nibble back that bone. So instead of opening up that full metatarsal area, knowing that she's got microcirculatory disease, is to create a super wound, is to nibble back into that bone, take away as much dead bone as possible, right down to some healthy bleeding bone. And then we packed it with antimicrobial beads, which are stimulant. We knew this patient was growing a Pseudomonas infection, and from this bone sample that we took again, we grew Pseudomonas. She was on gentamicin, but because of her deteriorating renal function, we had to stop the gentamicin and start her on oral ciprofloxacin. But even then, she reacted to this medication. So giving her stimulant beads or antibiotic beads with vancomycin and gentamicin covered all the organisms that we needed to, gram-positive and negative. So for those who are not familiar with this mixing of the beads, it's quite simple. It's calcium sulfate, pharmaceutical grade powder we use, and then we just mix the vancomycin, gentamicin, or whatever antibiotic you want to mix with that into a paste. And you have to be very quick at this point to make sure the paste doesn't actually set before you get it to that silicone bead tray. And then we make the beads and then pack them straight into the wound deep inside. The important thing is to get those beads right inside at the level of the bone and the tissue. And so why do we use antibiotic beads topically? So several reasons. So with gentamicin and vancomycin, you get initial super concentration of antibiotics local to the wound. And then it stays within the tissue in the wound. The drug elution and the resorption lasts for about 6 weeks. I found on average at least 6 weeks to 8 weeks if you use a 6mm bead tray. And then you get this continual flow of antibiotics directly treated locally. So I normally do x-rays in between, so you can see where the beads are sitting, so you can see exactly where they're treating and they're sitting on the bone. But because of the COVID situation, we weren't doing series of images for most patients. So after about 6 weeks, you can see that the beads are fully resorbed into the tissue. And then several weeks after that, you can see good, healthy bone mineralization, good cortical margins around that area there. So this is a patient that didn't have parenteral antibiotics or oral antibiotics. We just treated this with topical antimicrobial therapy, vancomycin and gentamicin in this case. And then we had a very good outcome after 15 weeks to full healing. So we have a nice pink healthy foot with straight line flow to the foot and a wound that's fully closed with good bone coverage and good healing of bone osteomyelitis. So the reasons why we use this topical therapy and the reasons why I chose this case is quite a challenging patient with vascular complications, because it eliminates the use of these nephrotoxic drugs on patients with renal complications. You get this high delivery of antibiotic directly to the wound, and you don't have to use oral antibiotics or parenteral antibiotics as well. It is effective against residual biofilms. So I've used this on patients with biofilms that are difficult to remove or painful to remove. And I've actually got good results with breaking down biofilms on top of wounds and good healing outcomes after that. It can be effective against poor tissue perfusion. The evidence around this says that you shouldn't use too much on ischemic type wounds, but we know that most of our patients have some ischemia, even though we revascularize them. you can use this topical type therapy. And potentially it's a cost saving for your patients, early discharge, less wound healing times, and also regimes of rehealing for dressings are obviously reduced because you're not taking the beads out all the time and you're not changing a different dressing. It's just the beads that do their job within that period of time. Thank you very much for listening.
Thank you, sir. Thank you, Professor, for such an elegant presentation. Now we'll move to the next presenter from Jordan, Professor Dr. Ma'moon Al-Bashir, presenting the ARCC module of wound care. Welcome, Professor. Walaikum assalam.
Thank you. Good morning, everyone. It's such a pleasure to be in Cairo again, and I thank Dr. Taha for the kind invitation. So our topic is the ARCC model of wound care. Getting the ARC, Comprehensive Wound Care Model. This is Noah's Ark, Safinat Sayyidina Nuh. And this is what I'm going to present to you, that we do need a model of comprehensive wound care that can span all care facilities and in all countries. Because over the years, and I've been working with this for in excess of 25 years, I see the things that have impact on healthcare are not usually the complicated interventions that are greatly described by our previous speakers. You know, they do make a difference to a limited set of patients, but with something so common as diabetic foot and wound problems, you need something which makes impact on the general public, on the population, on the volume of patients that we treat on a daily basis. We all know how heavy the burden of diabetic foot and wound problems worldwide, but they couldn't be truer than our part of the world, because the incidence of the epidemic of diabetes in our part of the world is amazing, and the complications we're getting a lot higher than either in the US or in Europe. We know also that having a wound problem or a diabetic foot problem is an ominous sign, because the mortality and the morbidity associated with it is immense. It's much worse than having colon of the CA or many of the cancers. It's quite sort of ominous to have this complication. And we know that patients who receive an amputation, most of them, 6 out of 10 will die within 5 years. So we're making a difference to their quality of life for these 5 years. And to make a difference, they have to keep the rest of their foot and they have to live wound-free. The etiology of leg ulcers and wounds are immense. Venous insufficiency takes the prime with about 70 to 85%, and the rest are all these spectrums of etiologies. The big three, however, are venous, arterial, and neuropathic, and that's what we mostly deal with. And that will go along the stairway of amputation, especially with ischemia, because all wounds are essentially ischemic, either at the macro level or at the macro level. The ARCC model is something we've developed following the checklist principle. And the checklist principle is an amazing thing because it's the bleeding obvious. It's something which has been there for a long time, have been used in the aviation industry for 30 years, and it's been very effective in reducing problems, accidents, and healthcare should be using this. The best known surgical check model is the one done by the Surgical Safety Checklist. Jordan was one of the countries, the 8 countries which participated in this trial sponsored by the World Health Organization, and they came up with the results, impressive results, that if you use a simple checklist in theaters, in the ORs, then you can reduce morbidity and mortality in most settings. Since then, it has been proven over and over again that it's such an effective model in reducing intraoperative and post-operative mortality and morbidity. So we took this model to apply it to wound care. And the idea is very simple, that we have a checklist of 4 stages that every single wound should go through. And if they go through, you should be achieving high rates of wound care, high rates of wound healing. And that's, to be honest, what we're trying to prove. And I've been speaking about this for the last 5 years in many meetings, hoping that it gets adopted on a wider level. So let me take you quickly through the ARC model, or the ARC. A stands for assessment, and that's straightforward. It's the history, the examination, the duplex, the investigation for infection, and you should essentially be asking, is there associated infection? Is there related ischemia? Which brings us to the assessment of the vascularity, and that's extremely important because especially in diabetics, most patients are ischemic. It's micro or macro. The R in ARCC stands for revascularization, and that's an essential step. And when we say revascularize, we're looking at the macro level to get pulsatile flow to the area, and we're also looking at the micro level because some patients would have patent major arteries, but they're still ischemic at the tissue level. And those have a different way of revascularizing them or improving their oxygenation to the tissue. And the ideas with revascularization, this is quite an extensive topic for a vascular surgeon interventionist like me because it's, it's a lifetime's work, but essentially the messages are you should obtain direct flow to the foot through tibial vessels. Some principles should be adhered to. The major anterior tibial, posterior tibial are very important. Peroneal can work, but is second class to the others. And if you get direct pulsatile flow to the foot, most wounds would heal. And there is a paradigm shift in revascularization because a straight, single line flow to the foot is very important. And that is uninterrupted flow that will get you pulsatile flow to the tissue as well. So you should open as many lines as you can without taking the risk of extra revascularizations. So if it's feasible and safe to do that, please do more than one vessel. If it isn't, a single vessel will usually be enough. The angiosome concept, I'm a great believer of the angiosome concept. I know been a lot of research sort of disputing this concept and emphasizing the fact that it doesn't make a difference which vessel you heal or don't. But in complex wounds, to be honest, I see it now and again that it's important to adhere to it. These days, the mini interventions are very fashionable, like everything else in life, and that's why interventional revascularization is more important than surgical revascularization. And that comes from a vascular surgeon. Until about 10 years ago, I used to do most of my revascularizations with bypasses. And I've done, the super ultra bypasses to the foot, all kinds of bypasses. But with the interventions, I'm seeing the value for the patient. It's lesser of a procedure, better results, and you never lose the option of surgical revascularization. Endovascular treatments, in my practice, usually I use the antegrade approach in most cases. I find it because most of these cases we're working with the tibials and we're crossing stenosis with all possible wires, catheters, etc. The end results is to achieve inline flow, pulsatile flow to the foot. This is the case 2 days ago where, a patient who's been struggling around with an ischemic wound care, etc., been attempted at revascularization many previous times at different institutions. And the problem was the foot because he has an anterior tibial working, but the ulcer is in the heel. Both posterior and peroneal are not working. And once we revascularize the posterior tibial and to the foot, it's a different wound altogether. Having said that, we shouldn't forget surgical revascularizations because they are very important. They have excellent results. They've been tried over and over again, but I will use them after I've done everything interventional. The angiosome concept, I'll come back to it. It's been described for about 30 years now, and it essentially states the fact that each area of the foot is supplied by a single a main vessel and a collateral from the other vessels. So if you want that area to heal, you better get that vessel which supplies it sort of revascularized. The C in the ARCC is for clean, so each wound should be debrided. You have to have sepsis control. We eradicate infection. We're very aggressive in our center with cultures, with control of sepsis, drainage when we need to, everything that should be done to minimize infection as much as we can. There are multiple organisms in diabetic foot, as you all know, and you should be sort of aware that resistant infections and horrible infections that we're seeing these days are the enemy. And if you want to treat your patient better, you should treat those infections. The last of the model is the C for cover. It's not the least. Coverage is very important. An open wound is an invitation for it to be reinfected. So as soon as you got your vascularity right, your infection eradicated, you should cover that wound. How do you cover it? You can use skin grafts, and that's my favorite method. Skin substitutes, extremely expensive, but I like them and they work. Vac therapy, all other methods. But coverage to the wound is very important. Do not leave it an open wound. Sorry. Can I finish the last few slides?
We can have a half a minute only, please. Mercy.
So I'm just going to take you through some pictures. You can use this model for the acute wounds. This is an acute post-fasciotomy wound, and that's what we do. Then we skin graft it for coverage. You can use it for the chronic wounds, extensive wounds. You debride them, you revascularize them, sepsis control, revascularize them. You go through the ARCC. Every single wound can work with using this model. These are just a few of the examples. I will not dwell on them. But I'll share with you a last slide of a brief summary of our results. We've been using the ARCC in our center. This is our center in Amman since 2016. To date, we've done 1,112 complex wounds. These are complex wounds, not the usual simple wounds. And we have an ulcer healing rate of 73% with bias against us, because 15% of our patients are untraceable afterwards. A lot of them come to us from abroad, and we count these as non-healed. Ulcer healing mean time is about 26 days for those that we have the data on. Thank you very much.
Thank you indeed, Professor. Now, proudly presenting from Egypt, Professor Dr. Hisham Mustafa, presenting a very important issue, the pitfalls of diabetic foot wound dressing. Professor?
Bismillah ar-Rahman ar-Rahim. I am Hisham Mustafa and my colleague Dr. Mustafa Nagar. To start with, I would like to thank my dear Professor Dr. Ahmed Taha and all the organizing committee and Mr. Chairman and all the attendees for your kind listening. We all know that wound dressing is an integral and important part in the management of diabetic foot. And I'm going to focus with my colleague on 10 pitfalls in diabetic foot wound dressing.
The first pitfall is to miss the main value of diabetic foot wound dressing.
This is very important. To miss not the values, to miss the main value. My question is, what is the main value of wound dressing?
The most important value, it allows proper assessment.
This is very important. We all go for wound dressing as if we are going to change something and put something else. And forgetting totally what is meant by the main value of wound dressing. The main value is that it allows really proper assessment. But assessment of what?
Assessment of wound, of the limb, of the patient.
What if you are going to do wound dressing and missing crepitus in the limb? What if you are going to do wound dressing and you forget that the patient is tachycardic or tachypnic or collapsing?
So we have to say we will assessment and wound dressing, not only wound dressing.
This is very important. At going for wound dressing, say I am going to do assessment and wound dressing in order not to miss the main value of wound dressing. So wound dressing needs an expert.
The second pitfall is non-familiarity with the ideal features of wound dressing.
Because of the foot is a complex structure and the etiology of diabetic foot is also complex and the healing process is complex, we have wide range of different dressing materials.
However, we don't have the best dressing, but we have the ideal features.
So the second point you have to remember that when you go for wound dressing, remember the ideal features of wound dressing.
The ideal features of wound dressing is non-toxic, non-allergic, non-irritant.
Easily stored, easy to apply and maintain, and mechanically stable and protective, and also biocompatible.
And also sterile, infection control, moisture control, gas transmission.
And also it is aesthetically pleasing, non-adherent, and do pain alleviation, and of course it should be available, affordable, and accessible.
The third pitfall, to go directly for wound dressing without wound bed preparation.
This is a common mistake. We have to start first by wound bed preparation. I think wound like this, you are not happy to go dressing for this wound and that's it. You need to do what is called wound bed preparation. In wound bed preparation, we apply the concept of time. Time stands for tissue preparation. We deal with dead tissue or deficient tissue. And I stands for dealing with infection foci. And M stands for ensuring moisture balance. And when we have an edge which is non-advancing or undermined, we should deal with. These are the methods used for wound bed preparation.
The fourth pitfall is to omit the surrounding skin from cleaning and care.
If you go to microscopic study of the surrounding skin, you will see that the surrounding skin is heavily studied by microorganisms. If you don't include the surrounding skin in your target during wound dressing, you are leaving multiple enemies to re-attack the wound again. So it's very important to include the surrounding skin in cleaning and sterilization.
The fifth pitfall is to focus on the wound and forget to optimize the systemic condition.
What's your opinion if you have wounds in patient which is anemic or hypoalbuminemic or has uncontrolled diabetes? I think wound healing will never occur.
The sixth pitfall is to mismatch between the type of the wound and type of dressing.
This is a very important point.
There is no conventional guidelines regarding the selection of wound care materials in different types of diabetic foot wounds.
We have different types of wounds and we have different types of wound materials, and we have to match between these types. Regarding the types of wound materials we know, we can classify these dressing materials into inert and interactive.
The inert materials like gauze, dressing, non-adherent materials.
And we can classify the interactive dressing materials into moisture retentive dressings, silver dressing and antimicrobial, and miscellaneous. These are examples for moisture retentive material. We have the transparent film, which allows wound visualization. We have the hydrogel that can hydrate the wound. We have the alginate, which can absorb a moderate amount of exudate, and we have foam, which can absorb excessive amount of exudate.
And we have a miscellaneous interactive materials like negative pressure wound therapy, electricity, magnetism, ultrasound, shock waves.
These materials act on the physical environment of the wound, and on the other hand, we have materials which act on the biological environment of the wound, like collagen and bioengineered and skin substitutes and growth factors.
The seventh pitfall is to mismatch between the target and timing of wound dressing.
Look for these types of wounds. Can you dress both wounds by the same frequency? I think if we have a clean wound you are targeting for epithelialization, you are going to dress it once every 3 or 4 days. But if you have infected wound with excessive amount of sedate, you have to dress it more frequently.
The eighth pitfall is to put gauze inside the wound.
And this is a very important mistake.
Missing gauze in the wound is considered a surgical error or malpractice. What if you intentionally put gauze inside the wound?
Gauze inside the wound should never be put except as a bag to control bleeding.
The ninth pitfall, to use tight bandage to control focal bleeding points.
This is very common, and even tight bandage during application of vac. Control of bleeding by tight bandage could be a catastrophe. You may lose the foot. Bleeding is best controlled by bipolar diathermy or underrunning suture.
The 10th pitfall, to adopt the same policy despite no progression.
This is the last focused point in pitfalls, is to persist on the same policy in spite of no progression. To summarize, please remember that in wound dressing, you have to remember the value of dressing and the ideal features of the dressing material. And when you focus on the wound, on the surrounding, on the systemic condition. And always match between the type of the wound and the type of the dressing in one hand, and the target of healing and the timing of dressing on the other hand. Please don't put gauze inside the wound, don't use constricting bandage, don't adopt the same policy if no progression of the wound. And I would like to thank you all for your attention.
Thank you, Professor, for the very instructive lecture. Now, may I invite the presenters, please, to the stage to answer the debates. This very fruitful session had a lot of questions and raised a lot of inquiries that please we would like to share. Please, the presenters, would you come to the stage? First of all, my sincere gratefulness for such very instructive lectures for all the presenters. I have tried to make my homework to gather the questions for each and every one. Professor Dr. Vainio Kavaratsu. The first question comes from Professor Dr. Ahmed Taha. Do you consider excising the tendon Achilles, and does this affect the ankle joint stability or not?
That's a very, very good question. Thank you. Yes. So infection eradication or elimination requires aggressive debridement, but at the same time stability. So if that part of the foot or ankle is going to be unstable, you should stabilize it. So we use temporary stabilization using threaded guide wires, which are normally used for the hip. We use between 2 to 4 passed in different directions to stabilize it. Sometimes we use an external fixator, a frame. So that is, it's really critical that we stabilize it. If it is just, the toe, then we always still stabilize with one wire. leaving one wire inside is not a problem because you've done a good debridement. Good question. Thank you.
Thank you. The next question comes from Dr. Gawish. He was questioning the pre-surgical usage of per oral antithrombotics prior to aggressive debridement. What's your advice, sir?
Okay, antithrombotics, no, we don't stop. In fact, we don't stop the whatever anticoagulation the patient has. And there is a clear reason why the patients were prescribed anticoagulation, because of the peripheral vascular disease. So we have actually published a paper, basically, even for very aggressive shock or foot reconstructions, we don't want to displease our vascular colleagues, so we don't stop the anticoagulation, but we use certain intraoperative techniques. So and also, the difficulty most orthopedic surgeons, certainly I had when I started, was to fully understand the anatomy of the vascular tree. That is not something, as an orthopedic surgeon, I get fully trained with. So I had to learn by myself, by interacting with my vascular colleagues. So it is really critical that we have a three-dimensional assessment of the vascular tree. And first thing is you try and avoid damaging those. And second thing is, yes, there will be bone kind of oozing. Yes, there are ways of reducing the bleeding intraoperatively a lot. But again, a very good question, but we do not use antithrombotic medication. But on the other hand, and that's a very good question because we use it a lot in other orthopedic surgery. When I do a hip replacement, always use antithrombotic medication during the induction.
Thank you. The next question comes from Professor Dr. Hani Zaid. He was questioning, in case of the of skin graft, why they take it from the foot, not from the thigh, for example?
Okay, skin graft we always take from the thigh. I do not think there might have been some misrepresentation in the picture. No, in that picture, we had taken the skin graft from the thigh. We do not take, but local transposition flaps, we do a lot from the adjacent, fasciocutaneous flap. But when it comes to a skin graft, it is almost always from the thigh.
His next question was about the residual function status after extensive bone and soft tissue debridement.
Very good question, and that idea really pondered in our mind for a long time. What is our goal? And we had fantastic lectures here, and amazing vascular surgery case examples given, amazing. Our goal is to achieve functional limb salvage. The limb is not only viable, but it is functional. For that functional limb salvage, we should have tissue that has adequate circulation and also mechanically stable, plantigrade, normal-shaped foot. So it is absolutely critical that is what is the starting point to achieve functional limb salvage in an infection presentation is infection eradication first. That is the starting point. If you don't achieve that, you cannot achieve no matter whatever clever vascular and orthopedic reconstructions do. So we start off with the infection control, infection clearance, infection eradication. Then we end up in providing full, stable, normally plantigrade foot.
Thank you. Professor Martin, you received the question from Dr. Hani Zaid. In case of major amputation, is it an individual decision or a multiple disciplinary team decision?
Sorry.
In case of major amputation, is it an individual surgeon decision or a multidisciplinary team decision?
It's a very good question. Of course, it's a multidisciplinary team decision because sometimes I think the approaching only for the surgeon eyes is not enough. I think we need all the input for any member of the multidisciplinary disease. Absolutely.
Professor Dr. Rashad questioned, in case if you have a necrotic bone discovered on plain X-ray, without any other symptoms, no ulcers, and non-symptomatic. What do you advise for this patient?
In the case that you find necrotic wounds without any other signs, I think that we have to think in two possible reasons. One of them is ischemia, and the other one is infection. Usually, infection is associated when it's presented with necrotic with other clinical signs. So in the majority of this case, the main reason for this necrotic presentation is ischemia. So my recommendation is to do a proper assessment to discard ischemia in this kind of patient before to approach with any other treatment.
Thank you. Dr. Adel Amhawi asked, is there positive, after the probing test is positive, what's next?
Probe-to-bone test, I think this is one of the main assessment that we should do in every diabetic foot patient. What next? If you are touching bone, this is my personal opinion, if you are touching bone, the presence of osteomyelitis is very likely. So that means that in the majority of the case, the patient suffers from osteomyelitis. And in my opinion, if you are touching bone, you need to start to treat. This is my recommendation. Of course, what say the literature? The literature says that you have to combine probe-to-bone with S-rate and the clinical inflammatory marker, especially PCR and erythrocyte sedimentation rate. But personally, if I touch in the bone, my personal opinion is that the patient suffers from osteomyelitis.
Thank you, sir.
Thank you.
The questions for Dr. Dr. Martin Arizol. Dr. Ahmed Ismail questioned, can stimulant work on osteomyelitis of the calcaneus bone?
So Martin Arizol he's joined
online,
remotely.
yes.
If he's live,
Shall we
should be able to answer.
Shall we carry the questions for the online speakers, or they are not among us now? Professor Martin Arizol, can you hear us?
He's online, but we're not sure if he can hear us right now.
What is the question again? Sorry.
Can stimulant work on osteomyelitis of calcaneus bone?
Okay, I work with Martin. Yes. So again, you know, my friend Jose's comments about osteomyelitis. When you touch the bone, there's a high likelihood of osteomyelitis, and we all agree. So there are different types of bone infections. Osteomyelitis, by definition, it goes into the marrow. You know, osteomyelitis was originally described for long bones. So where you have the diaphysis, epiphysis, metaphysis, and it starts at metaphysis, runs to the diaphysis. So long bone. So whereas what we see quite often is surface osteitis. So the area where it touches. So surface osteitis is very common in calcaneal bone infections that spreads from the calcaneal ulcers. So in that situation, yes, if you are dealing with just the soft tissue wound, the way Martin has shown, using calcium sulfate pellets, antibiotic loaded, they work very well. But if the bone is affected, we routinely do, we take that surface of the bone off until where you see the green zone, and then we make multiple drill holes, and we inject antibiotic loaded calcium sulfate preparation, which comes as injectable material. And we had published a reasonable size series on that. And that is a very highly successful technique. So again, you excise all the necrotic bone, keep going until you see the kind of green zone, but there will still be microscopic infection. So you make multiple drill holes based on the bone biopsy results, you know which organism it is, which sensitivities are, use the appropriate antibiotic-loaded injectable ones, fill the drill holes, and it usually results in infection eradication.
Thank you. Well, I have a question myself to all the presenters and the chairpersons. We have all emphasized very clearly on the importance of revascularization of the tibial vessels. What about your experience you have seen when targeting diabetic feet for the below the ankle lesions and the necessity of their intervention?
Sorry, if I may. I think revascularization is the essential, most vital step in any of these cases. Nothing works without vascularity. I was so glad to see the great cases the doctor exposed. However, that extensive of a surgical debridement will not happen if your vascularity is no good. And the better vascularity you can get, the better result you will get. Foot vascularity is extremely important when you have a foot problem, and the foot vascularity would sort of indicate that only to the ankle doesn't work, collaterals don't work. Having said that, I do have a few cases of revascularization to the tibial with occluded foot vessels that worked very well, mainly in Berger disease. And I do some Berger disease surgeries because you can't accept these teeny weeny little vessels and if that happens, then I use adjunct things like hyperbaric oxygen therapy, local oxygenating factors like Granulex, even local oxygen in a bag, and they seem to help a bit.
Can I comment something concerning this? I think it's very important that the people are ready to change the paradigm concerning peripheral arterial disease, especially because some time ago, I think 15 years ago, more or less, we're talking about below the knee revascularization. I think more or less 5 years ago, we are talking about below the ankle revascularization, and now we need to talk about a small vessels in the distal area that sometimes is not able to revascularize, and this is the becoming to the new techniques at venous arterialization or something like this. So something that, in my opinion, is a learning lesson is what happening in the countries that we have, for instance, in Europe, higher prevalence of peripheral arterial disease. And this is the evolution of the arterial disease in passing with diabetes. So I think it's very important not talking only in below the ankle, but talking now in a small arterial disease problem. And for this reason, I consider very important the previous lecture concerning the assessment of the oxygenation in the foot, because probably it's the next step in order to assess properly the vascular status of the patient.
Could I extend the question for the panel, please?
About the question from Dr. Taha, which is about the Achilles tendon. I think it's a very interesting topic. We've all struggled with exposed Achilles tendons. When you have a diabetic foot and the skin over the Achilles is gone, they're extremely difficult wounds to heal. And in my experience, you almost always end up excising the Achilles tendon. And what I do, I sort of use usually the vac instead until I get excellent granulation. And in a minority of patients, you need orthodesis, where you fix the ankle with cement, etc., percutaneously after you've covered the skin completely.
So, by the way, that patient had undergone a combined hindfoot and midfoot reconstruction. So had hindfoot arthrodesis, and you might have noticed the midfoot was also deformed. But the starting point is that patient, a very prominent person in the society, and was actually at that time busily working on a Hollywood movie, a trilogy movie, very busily working on. So he ignored his foot, and then, being a massive VIP, seen in local university hospital. So the goal was to achieve infection eradication. Otherwise, no matter whether you use external fixator or internal fixator, you don't achieve functional limb salvage. So yes, shown that part, but that was followed by hindfoot plus midfoot combined reconstruction. Good point.
Well,
in any target lesion revascularization, I'm speaking concerning below the ankle revascularization. For any target lesion revascularization, we should consider takeoff and runoff. And for the below the ankle, we may consider the digital arteries as the runoff. However, actually, we are revascularizing the runoff, which is below the ankle. But very important point, if you are going to revascularize below the ankle and the patient has a wound, please expose the foot, as you may encounter bleeding unnoticed below the draps, and you complete your procedures not noticing that the foot is bleeding much.
The last but not least questions goes to Dr. Hisham Mustafa. Dr. Reid Khariba was questioning, in preparing the bed, the wound bed, do you go mostly for chemical debridement or surgical debridement?
I think if we have a major necrotic tissue, you need surgical debridement. If you are left by minor necrotic tissues, you can leave it for chemical or enzymatic debridement.
And the last question, do you pack the wound by silver dressing?
Packing after debridement to stop bleeding. but we are not going to back in any time later.
Well, I really appreciate very much the outcome of this session. The chairman and the presenters were just delivering crystal clear messages. I congratulate you for such a success, and my congratulations are extended to Professor Dr. Ahmed Taha for the success of this conference. And please may I call the next moderator for the next session.